はい、皆さんこんにちは。Welcome to invited lecture session. This is a collaborative session of Japan Endometrial Society and World Endometrial Society. It is my great pleasure and honor to introduce Professor Stacy Mismar. Thank you very much for coming, Stacy, to Japan. Her CV and abstract is on 57 pages of our abstract books. Briefly, I introduce her. She is an endowed professor of obstetrics and gynecology and reproductive biology at Michigan State University, and also adjunct professor of epidemiology at Harvard T.H. Chan School of Public Health, and lecturer in pediatrics at Harvard Medical School. She has over 350 papers, and she has been a leader of collaborative research in the United States and in the world. And she's very, very famous scientist in this field. And in May 2023, Dr. Mismar became a president of the World Endometrial Society. Today, she will talk about endometriosis, causes, consequences, and collaboration. So please start your lecture.
Thank you very much. Thank you, President Harada. Thank you, President Iwase. It is really an honor to be here, and I appreciate especially all the accommodation for my English language presentation. And I hope that with our brief time together, the main message to convey is that of collaboration and opportunity collectively, especially as an epidemiologist thinking about diversity of populations, diversity of points of view, diversity of types of clinical care and excellence. And certainly, as you'll see, Japan has led many of these footprints, and so it's quite an honor to be here. So I first started my scientific discovery in endometriosis in 1998, joining the Nurses Health Study group. And our initial work of data collection and focus was really trying to look at the first predictive models, first longitudinal studies of risk factors for endometriosis. And so we began in the Nurses Health Study 2. This is a cohort of U.S. female nurses, almost 120,000 of them. They were enrolled in 1989. At that time, the youngest was age 25, and we are still following these very dedicated participants over all of this time. This work mirrors the excellent Japan Nurses Health Study, which of course was launched here, overseen by Professor Hayashi, and has expanded across the country and many groups that has now grown into the Japan Study Group on national occupational cohorts of women health professionals. And so a lot of the data and understanding that we have about risk factors are complementary between these two U.S. and Japan-based nurses' health studies. So when we think about what we know in terms of risk factors for endometriosis, we see that they really cluster into different windows of exposure across the life course. We also see that there's actually a fairly small footprint of discovery. Again, these unusual prospective cohorts of the complementary U.S. and Japan nurses' health studies has contributed to and driven a lot of this knowledge, but especially for young people in the Japan Society on Endometriosis and across the globe, there is a lot more work that can be done, so it's a field very ripe for further discovery. Consistently, we have found in terms of in utero and early life exposures that those with endometriosis tend to have lower birth weight. There's some inconsistency about whether they also have a premature delivery or not. That is complicated by the strength of the low birth weight finding that dilutes and crowds out the gestational length finding. Also, there is strong and replicated but yet understudied evidence of DES exposure, and this is also akin to the field of phytoestrogens and other exposures around estrogenic effects. Next, we look at childhood and adolescence. Again, the literature and evidence here is quite sparse. We see very consistently across case control and cohort studies that an earlier age at menarche is a hallmark of girls who eventually are at risk of developing endometriosis, and also very consistently found across populations that a lower body mass index at ages 5, 10, age 18 are consistently found to be another hallmark of endometriosis risk. Understudied, and by understudied, there's really only 2, and some of these maximum 3 studies that have looked at physical activity. There's some suggestion that frequent high-intensity physical activity, or particularly around the time of menarche, may be associated with increased risk. We have to be very cautious about those types of conclusions, especially when they're counter to other broader health recommendations. There also seems to be some increased risk of passive smoke exposure, but again, not consistent. And then skin sensitivity, meaning risk of sunburning, presence of dysplastic nevi, and other dermatologic conditions, which have been found in, again, consistently, but in a small number of studies, which is fascinating when we think of the entire whole health of girls and women with endometriosis and how multiple systems are coming into play. Now, most of the discovery has been in factors in adulthood. And so, again, for diagnosis in adulthood, we still see this consistent menstrual cycle length and lower body mass index. There is great inconsistency in terms of alcohol use, with as many studies showing an increased risk with greater use, but also a protective effect of alcohol use, for which there really isn't a clear biologic hypothesis. Inconsistency around caffeine. There is very strong animal model and bench data showing that PCBs and dioxins have an increased risk. However, there's yet to be a statistically significant human study, in part driven by windows of exposure and the difficulty of following long-term those who have large dioxin exposures. There also is evidence of a higher prominence in those with red hair, or again, those skin factors of freckling, moles, skin sensitivity, but again, inconsistent. And then, of course, on the protective side, very consistently, those with higher parity have less likelihood of endometriosis diagnosis. It's unclear if that's through a true difference in endometriosis prevalence, or if that's related to parity and decidualization of the endometrium and pain relationships, then suppressing the symptoms associated with endometriosis. Also, inconsistent around cigarette smoking, perhaps some difference when endometriosis is concurrent with infertility versus not. And then again, a whole list of understudied. And unfortunately, one of the largest areas understudied in adults is around dietary factors. And there's great patient interest. There's certainly great interest in terms of a modifiable factor that can be recommended by clinicians for patients. And so far, the good news is the data seem to suggest, although sparse, that really the hallmarks of a healthier diet, lower red meat, higher fish intake, Higher fruits and vegetables, particularly citrus fruits, seem to be beneficial, and then low-fat dairy and minimal trans fat intake. So the good news for patients is that it really is consistent with what already would be healthy recommendations, but we would like to better understand these and solidify if these pathways are robust, if they can be more targeted and intervened upon, and then also what this tells us about the physiology of endometriosis establishment, but also recurrence. So again, when we think across the life course of those with endometriosis, we know that at some point there is a phase of initiation and development. We're very unclear what that window is to symptom onset. We know that it likely varies highly among patients. We don't know what drives that. And then thinking about coexisting and subsequently occurring conditions. And so thinking all across adulthood, specific to endometriosis emergence and presentation, but then also thinking about what is it with those overlapping with other conditions? What is it that's pertinent for your patients? And then what is it that's pertinent for our better understanding about the biologic underpinnings of both endometriosis and those conditions? So we started to think about this with endometriosis as a high-risk group 15 years ago now. And again, those data are emerging. This is where studies like the Nurses Health Study, the Japan Nurses Health Study, have a great opportunity to look longitudinally at endometriosis patients and what happens with their health over time. And so there's a lot of plausible hypotheses here. We know that endometriosis induces systemic changes, inflammation, oxidative stress, the altered hormonal milieu, stem cell activity, of course, with attraction to the peritoneal cavity. And we know that there is likely malignant transformation, at least for ovarian cancer. We also know quite definitively now that there are shared genetics and pathophysiology among endometriosis and other conditions. And also, of course, there are shared risk factors. Some of the demographics and the risk factors that I just described are also associated with some of the conditions that I'm going to talk about now. We also know that there are some associations between treatments for endometriosis, certainly common ones like oral contraceptives, and long-term health outcomes. For example, women who have a higher and longer exposure to oral contraceptives have a lower risk of ovarian cancer. And some of these are in obvious directions, and then some of them also are in counter and perhaps even remediating directions for those with endometriosis and their health. So thinking in adulthood and looking forward, I also want to start with conditions and symptoms and multisystemic health that emerges in adolescence. And I know that Dr. Sasamoto very kindly described to me some of the discussions yesterday around treating adolescents. And now we're thinking about what the non-gynecologic emergence of symptoms and conditions is in that time frame. So described a little bit yesterday, for those of you who saw Dr. Sasamoto's presentation, we have the A2A study, the Women's Health Study from adolescence to adulthood. Across 6 years, we enrolled nearly 800 patients who had been definitively surgically diagnosed with endometriosis, and then a complementary nearly 800 participants who've never been diagnosed but were from the hospitals where the endometriosis patients were treated or the surrounding catchment area geographic region. So this is quite a young cohort. They are an average of age 19 or a median of age 19 at enrollment. The controls are just a little bit older. And they have a very specific endometriosis-related presentation. And so 96% of them had pain prompting their diagnosis. They had an onset of those pain symptoms at an average of age 14. Their ASRM stage, 95% are stage 1 and 2, and 94% only present with superficial peritoneal lesions, at least at their diagnostic surgery. And so we've been following these participants since their enrollment. And thinking specifically at baseline, we started to look at what their other conditions are. So one of the, and I know many of you clinicians know that your patients not only are expressing pelvic pain, but also pain at other sites. Migraine is a particularly, especially among adolescents, a particularly prevalent symptom. And in fact, when we look in this cohort, we see that those with endometriosis have 5 times the odds of also experiencing life-impacting migraines. And that is robust even to when we, in the final model, it takes to 4 times the risk. That's accounting for the pelvic pain. So if we remove the influence of this might just be a pain-presenting patient, we are still seeing extremely strong odds associated with migraine. We also were interested in looking at these very early ages. Are we seeing evidence of immune-mediated conditions? And indeed, in these participants, looking at emergence of autoimmune conditions, lupus, multiple sclerosis, rheumatoid arthritis, fibromyalgia, type 1 diabetes, hypo and hyperthyroidism, chronic fatigue, and then also at allergies, asthma, skin conditions, eczema, Sjogren's, irritable bowel syndrome, psoriasis. When we look at those other emerging immune-mediating conditions, we see that our participants are, the more immune-mediating conditions they present with, the more likely they are to be among the endometriosis cases. And so at these early ages, we're already starting to see this multisystemic disruption. Also, this will not be a surprise to anyone here. Our endometriosis patients are 5 times more likely than those without to also present with irritable bowel syndrome and symptoms. So also returning to that Nurses' Health study, now moving from adolescence into adulthood conditions, and I know there was some discussion about this wonderfully yesterday, that we have observed and explored the relationship between endometriosis and cardiovascular disease. And indeed, those with endometriosis had a significantly higher risk of myocardial infarction, of angina, of receiving a CABG or a stent intervention. And combined, we saw about a 60% increased risk of these cardiovascular events. Now, interestingly, and we have this benefit in the nurses cohort of looking across a long period of time and across these age groups. And in fact, with the incidence by age of cardiovascular events in those with endometriosis being in red, and the incidence in those without endometriosis being in blue, we actually see that the strength of this relationship, those with endometriosis have significantly higher risk of cardiovascular events up to about the age of 55. And as they emerge into those age ranges where the cardiovascular events for the whole population become much more prevalent and higher incidence, we now no longer at these later ages see evidence of a difference for endometriosis. So whatever it is that is physiologically relating endometriosis to cardiovascular disease, it really is having its impact in earlier onset events. Also, Dr. Sasamoto has kindly conducted a meta-analysis across, these are the 4 prospective cohorts. There are some other cross-sectional studies and case control studies, but when we look at the prospective cohorts, we see a meta-analytic summary of 1.4. That's slightly below. We still have the largest effect size in the nurses, but that may be also because these other cohorts have a higher weighting to older ages. And so remember, as we get to higher ages, the association with endometriosis begins to attenuate. We also conducted within the Nurses' Health study, Leslie Farland, a former postdoctoral fellow who is now an assistant professor at University of Arizona and leading projects in her own right. We explored the relationship with stroke. Very similar to what we see with cardiovascular disease, a 50% increased risk that really is fairly robust to potential confounding factors associated with endometriosis and cardiovascular disease. So there's definitely something happening here in the physiology of patients with endometriosis for their long-term cardio and cerebrovascular health. And one of the next key questions is, can we determine what those pathways are, and can we intervene upon them? And might there be early screening and interventions for the development and the early signs of cardio and cerebrovascular conditions? And can we target care to maximize long-term health for those with endometriosis? We also have one of the largest areas explored has been autoimmune diseases. Quite consistently, Mary Lou Ballweg from the U.S. Endometriosis Association, now more than almost 30 years ago, has surveyed those with endometriosis, a large proportion, over 2,000 women, and there were cross-sectional reports of autoimmune diseases. That discovery has really evolved. This is a great meta-analysis from Karina Zondervan's team, looking at, again, even though this is a key area of interest, we stay fairly small in the number of studies in this footprint, which on the one hand remains frustrating and difficult, particularly for clinical translation, but is a great opportunity for young, eager investigators. But we see very consistently, no matter what study design we're looking at, we see significantly greater risk of those conditions that, again, interestingly, in the adolescents, we're already seeing early evidence of emergence. So lupus, the strongest was a Sjogren's and irritable bowel disease associations. Multiple sclerosis has a very strong association, but again, only 3 studies to date. Now, certainly the footprint that has had the greatest attention is in cancer. And so the first time there was a publication referring to endometriosis and cancer was 1946. And there's a lot of hallmarks here. There is abnormal tissue growth, but interestingly and informatively, for endometriosis, we don't get the uncontrolled growth. The surgeons, you don't see filled peritoneal cavities with endometriosis, endometriotic lesions. But there is abnormal growth, certainly. There are development of local and distant foci, resistance to apoptosis is consistency, invasion of other tissues when we think of deep endometriosis. And then we know that the endometrioma and deep endometriosis harbor somatic cancer driver mutations. From Anglesio and colleagues, this publication from 2017 really was exciting. They focused on deep endometriosis and was the first evidence that those cancer driver mutations existed in that tissue, which is fascinating because certainly in the endometriomas, we have the clear expectation of that metaplastic transformation of the endometriomas. There's not that same local transformation into cancer cells for deep endometriosis. So the fact that they have similar prevalence of those driver mutations really now leads to many more questions, actually, than answers. And Marina Kavaskov, a former postdoctoral fellow on our team, who's now a professor at the University of Paris, led a meta-analysis of the data that exist on cancer. She also, and I know that we're waiting very excitedly for the Japan guidelines for endometriosis that will be coming soon, led in large part by people in this room and in this society. She led the summary of information for endometriosis cancer in the European guideline. And I'm going to start sort of more distally, again, thinking about how fascinating and complex endometriosis is. There have been 20 studies. Most people don't realize that this is a large area of investigation, looking at endometriosis and breast cancer, showing a statistically significant, but only a 4% increased risk of breast cancer. Part of this may be driven because we have one study and only one study in the U.S. Nurses Health Study 2 that has suggested that actually there's difference in endometriosis risk for breast cancer by breast cancer tumor type. And we see the risk solely in those with ER-positive, PR-negative breast cancer. This has to be replicated. We should not take this as a definitive conclusion, but that also may explain why we see this significant but very low overall association with breast cancer. Endometrial cancer, interestingly, there's been quite a lot of study here, but it not statistically significant difference. Some of this is driven because some of the studies discover the endometriosis and the endometrial cancer at the same time, and so temporal associations and causal inference is very difficult, but quite believed and assumed a real association. We're not seeing statistical significance overall in the human data thus far. Melanoma also, there were two very consistent and exciting findings early on, but that has not consistently borne out. Close to statistical significance again, but with those 7 studies, a suggestion of an association, but not definitive. Also, interestingly, I find that in our societies and professional meetings, in our journals, we're really not talking about endometriosis and thyroid cancer really at all. But there have been 5 studies to date, strongly statistically significant. And for those of you familiar with the statistics of an I-squared value, that is calculating the amount of heterogeneity, the amount of difference among the studies being summed together. No difference whatsoever, 0 heterogeneity, extremely robust finding. Of course, the association that we know the most about, that has been the most studied, 24 studies to date, is with ovarian cancer. There is a meta-analytic doubling of risk. And really, when you look at that column of the meta-analytic and each of the individual studies on this forest plot, all of the studies are finding an increased risk of some magnitude or another. Now, I want to really reinforce as the clinical patient take-home message that when we look at those 3 cancers that have been statistically significantly associated, we really need to consider the difference between relative risk and absolute risk. And so the lifetime risk of these cancers in all women is in that first column. So for ovarian cancer, for example, the lifetime risk is 1.3%. In women with endometriosis, it's 2.5%. So that's the largest difference. But even with this robust, very clear, and we have strong hypotheses for why this would be, we're actually seeing a very small lifetime difference in risk, only 1%. And for breast cancer, it's 0.5%. And for thyroid cancer, it's 0.5%. So while this is important to know, it's important to also not scare patients that they are destined to have these cancer outcomes. And indeed, the European guidelines included this infographic trying to graphically display for clinicians and patients what this actually means. So I'm going to zoom in here on ovarian cancer. Each of these grids has 100 bodies representing 100 women. And so for ovarian cancer, a lifetime risk of all women is 1.3%. And so there's one blue body and then a small portion of the next. For those with endometriosis, it changes to look like this, 2 and not quite 1/2 of risk. And so in the solid black, those are all of the women who, with endometriosis, who will never develop ovarian cancer. So this is very important to relay to patients. Also, when we think about ovarian cancer, we need to think about these histotypes. And so what we know for ovarian cancer is that actually the association really is with clear cell, endometrioid, and serous, particularly high-grade serous ovarian cancer. That really is where all of the association lies. And a key question is this everyone with endometriosis, or is it actually just those with endometriomas? There actually has been only 1 study to date that has looked at superficial peritoneal and deep endometriosis associated with ovarian cancer, 4 studies looking at endometrioma. 1 study in all the world that has cross-classified endometriosis macrophenotype with ovarian cancer phenotype that found an increased risk between endometriosis and ovarian cancer with endometriomas. Also found an increased risk with superficial peritoneal, but not with deep endometriosis. So we have a lot more discovery in this footprint to do. Of course, we know that Heterogeneity and classification of conditions is absolutely essential, the cancer world has certainly been revolutionized. Breast cancer in particular, as an example, we know that even just branching between ER positive and PR positive, there are different pathways, they demand different treatments, they have different prognoses. We also know that they have differences in association with risk factors. And so the risk factors that we knew to be associated with breast cancer, largely family history, benign breast disease, menarche, breastfeeding, were associated with both. However, when we split between ER positive and ER negative breast cancer, we see that actually some of the associations go in opposite directions. The BMI association is more obesity is associated with ER positive, lean body mass with ER negative, and parity also has an opposite association. And so the key thing here also is circulating hormone levels, which are hallmarks of breast cancer risk, really just associated with ER positive breast cancer. And so this was obscured when we had treated breast cancer as one condition. And we're now doing the same with endometriosis. And important is considering what these prevalences may be. We know for endometriosis that there's obvious diversity of surgical visualization. We also know that the clinical phenotype, what your patients present with, is highly variable. We're now seeing the emergence of variation in the systemic effects of endometriosis. And so for endometriosis, we don't yet know what these different branching and informative characteristics will be, and that's where a lot of focus of current discovery is. So we know that visualized stage actually is not associated with symptoms or predict treatment response. And the goal really is to take together all of these aspects of biomarkers, genomic knowledge, the macro surgical phenotype, the symptom presentation, the systemic consequences and conditions, and really emerge to stratified and personalized care for women with endometriosis, as well as considering where they are in their life course needs and emergence of symptoms. Looking at the A2A cohort, Dr. Sasimoto has done some really exciting new work looking at the proteome and starting to give the emergence of differential classifications and subtypes of endometriosis. So I'm not going to go into all of these details, but the rows are individual proteins. Those with a red dot have upregulated expression. Those with blue dots have lower levels of the protein. And across the columns are the lesion color at surgery. So the first column is red, then vascularized, then white, then blue-black, then brown. And the key focus here is that we're seeing differences among them, which is fascinating. Dr. Sasimoto also followed this work on by looking at this is the same rows are proteins, red is upregulated, blue is downregulated. Here the columns are pain presentation. So dysmenorrhea, acyclic pain, life-impacting pain, remaining life-impacting pain a year after treatment, bladder pain, and bowel pain. So again, showing that we're starting to see differentiation among these subtypes. Now, when we look longitudinally, also I think presented a bit yesterday, we're able to look across time in this diagram where the pink rows are those who at baseline had severe acyclic pelvic pain. The yellow are moderate, the blue are mild, and as you can see over 2 years, they follow very different patterns. And so a key goal of ours is, can we predict, are there markers that would be clinically relevant for those who remain severe across the whole 2 years? Can we predict, and are there markers that are relevant for those who go severe and shift to none or mild pain by year 1? And so elucidating this and predicting so that clinicians can have a better sense of what their patients' likely patterns and responses will be is critical. Dr. Sasimoto has also looked at widespread versus local pain and seen differences, and this may start to get the underpinnings of why some of your patients look differently depending on where their pain is being expressed. We also looked at the genetic basis of endometriosis and comorbidities with other inflammatory conditions. We see 42 loci, but these loci are more strongly associated with stage 3-4 disease, and actually that's driven by endometriomas. So it's the endometriomas that are showing the strongest genetic loci associations. We've looked at these subtypes and diminishing sizes because the data are difficult. Right now we have 60,000 women, but we get to very small sample sizes when we look at subphenotypes. We're currently expanding this. However, again, one of the hallmarks is the effect tools. And so all of this subphenotype discovery really requires collaborative large sample sizes. We have produced these tools that have been contributed by Dr. Harada and many others that now summarize a common way of collecting surgical information, clinical information, and patient information, as well as protocols for fluids and tissues discovery. There are 58 sites currently in 24 countries. They can be found on the main Worth Effect website. Also, those centers, we have translated the tools into multiple languages. Note that Japanese is not included. And so this is a great opportunity for the Japanese Society of Endometriosis to lead the world in this production. And just some evidence of what has happened in regions where these translations have occurred. In India, that translation resulted in 11 centers that are collaboratively now working for endometriosis discovery. In Central America, there are now 11 countries with those Spanish translations. In Turkey and the Middle East, there now is a large research initiative, as well as Mira Musa in these 23 Middle Eastern countries. And so these translations really do catalyze work. They've also catalyzed collaborative efforts through funding. So there's the Female Project, which is a pan-European collaborative effort. There's also a large project led by Linda Giudice that it combined 7 countries and sites across the globe through many countries that have this harmonized data and details. I'm going to skip forward for that. And then we are leading a combination of 2 US sites and Oxford looking at variation to discover what is endometriosis. And so these tools really have been essential in expanding knowledge. Paul Young is leading a new tool around physical exam documentation. Matthew Leonardi is leading a new tool on imaging documentation. We have new tools coming for best practices for experimental models. And I really want to, again, as I conclude here, reinforce the importance of collaboration and spirit. With respect to the World Endometriosis Society, there is no country that has a larger number of senior ambassadors for WES. And of course, Professor Harada and Professor Koga have each served on the senior board for WES. Also, we have a mentoring program where there are senior mentors, and they are matched with junior, both scientists and clinicians, for a paired match. We match 1-to-1 who, over the course of a year, have the opportunity to talk to each other and get career advice. Sometimes it's as simple as preparing for interviews. Sometimes it's more specific. But this has been a great opportunity with a lot of contribution from Japan. We actually only have an early career WES ambassador who is within 10 years of completion of their final degree. We actually have one with ties to Japan, and that's Dr. Sasimoto, who, of course, trained in Osaka, but now is at Harvard University. And so I wanted to highlight here that 2 months from now, we are going to have a large call for self-nominations to both senior and early career ambassadors. And I really encourage you, as well as encouraging your trainees to apply to become ambassadors, and also to consider becoming part of that mentor and mentee program. And so I will just conclude reminding that many of us will be attending the Asian Congress on Endometriosis in September in Bali. And following that, in May of 2024, we will have the next World Congress on Endometriosis. Those abstracts will open right around the time of that Bali meeting. All of this work could not have been done with my amazing team, including Dr. Sasamoto, but we have a large group of wonderful collaborators. And so I hope that spirit of collaboration and teamwork comes through in the importance of how much we have left to do, but really the exciting advances that have occurred over the last 10 to 20 years in endometriosis discovery. And I thank you.
Thank you very much, Professor Mismar. Your great talk about endometriosis and collaboration work all over the world. We have a short time for question or discussion. And I want to ask one question. Do you know there are some data about, you show that endometriosis causes a systemic effect, like cardiovascular disease and autoimmune disease. Do you know some data about medical treatment
Excellent question.
may affect the incidence of such
It's an
disease?
excellent question. So the studies to date have been able to look at oral contraceptive treatment that has not had a strong effect on either benefiting or detrimental effect for those other health outcomes. We have not been able to adequately look at GnRH agonists or antagonists. There just hasn't been long enough data with detailed enough information. So that's something that definitely needs to be explored.
Yeah.
The other key area is hysterectomy. So we know that women with hysterectomy or women with endometriosis are more likely to have a hysterectomy. They're more likely to have surgical menopause. And what we're seeing, not for the autoimmune conditions, but for the cardiovascular and the cerebrovascular conditions, that because there's emerging evidence that hysterectomy itself can be a risk factor, that actually that is explaining a portion, about 40% of the relationship between endometriosis and cardiovascular disease.
Okay, thank
So
you.
the key message is we don't completely understand the lifelong influence of the uterus, but there definitely are some longitudinal effects. And so considering prioritization and import for hysterectomy carefully is quite important.
Yes. And you don't have a data about progestin also?
We do not specifically.
Yes.
Exactly. It's one of the difficulties, and again, the Japan Nurses Health Study, and especially the new enrollment into the Japan Nurses Health Study 2 may be able to address this. The cohorts did not have endometriosis and reproductive health interest initially when they were established. And so they didn't collect the level of detail, for example, of very precise progestin and GnRH agonist and antagonist data that we would like to have.
Okay, thank you. Dr. Sasamoto.
Stacey, thank you so much for your wonderful talk, as always. I was wondering if you could talk a little bit about what's known about racial differences in these associations, including Asians, since this is Japan.
Yes. So excellent question. So I'll start with in the GWAS, the genetic ancestry footprint, all of the data are European ancestry or from Japan. Japan is the only contribution that is of ancestry other than European ancestry. So that is both very exciting, but also something that needs to be expanded upon. We don't have information on the genetic underpinnings for other race ethnicities. What we do know is, at least in the US and Europe, we see quite consistently that women who have Black or what in the U.S. we would term, and there's very different terminology across the globe, but Black or Hispanic race and ethnicity have a lower likelihood of being diagnosed with endometriosis. That's the key term, though. We don't have accurate data on true endometriosis prevalence, and if it differs by race, there's a lot of evidence of differences around access to care, belief about pain symptoms, response to infertility expression. There are systemic biases that the truth may be that there actually is not a racial difference, and it is more built into barriers in the healthcare system. But the short answer is we don't know definitively yet. Thank you.
Okay, thank you. Very good
Excellent.
question. So, time has come, and thank you very much for your excellent talk. And I hope we can be involved in this, your
Absolutely.
collaborative work, especially WAF.
Absolutely.
We should start soon.
Yes, it would be wonderful. Thank you.
Thank you very much.
Thank you.